the exam for blueprint. I was like,
Oh, did it pop up? Oh, sorry. That was from last year, just so you know. How's that? Sorry about that. I should have deleted it. I thought I deleted all those, but.
Are you on?
Are you on?
Yes.
Can you hear me now?
Yes.
You guys want to show us your faces?
Oh gosh. Where's it at? Hi.
Hi. So here's the deal, ladies. We'll have you on. We're going to do a review of medications. So this week is going to go a little different than we thought, just like what you thought. Kathy was going to teach this lab and she's not feeling well, so I'm going to teach it, which is super cool. And then tomorrow we're going to do lectures. So I just thought I wouldn't change it up on you again since it was on the schedule that Kathy was going to be teaching this lab. So I'm just going to teach the lab that Kathy was going to teach today. And I'll be teaching the one on Thursday too. Kathy and I were going to do that together, but I kind of anticipate she probably won't be back on Thursday, so we'll see. We're going to go over meds 11 through 15 first off, so if you want to get your med stuff out. And then we will also, after that, kind of do a review. Yes?
Caitlin wanted me to tell you that she's going to be
Caitlin Tooley. Okay, perfect. All right, so first of all, I have to get passes from everybody. So if you would show me your pass. Kathy has my clipboard for signing you in, so I'll just give you a blank piece of paper to sign in. Perfect. Okay. I saw your chart. Okay. Just give it a minute. Can you guys hear me okay? Okay. Just shake your head.
Yeah.
Just hand that around, Sammy. Did everybody have a good weekend? What's that? Yeah?
Yeah.
Perfect. Let me get switched out here. Okay. Did everyone get their videos uploaded okay? Any problems with that? Okay. So I think Kathy's going to kind of review those while she's at home this week, so we'll go from there. Foley catheter, how's everybody doing with that? Have you guys been practicing Foleys? Have you been doing your vital signs? Those are two more extensive test outs because of course the Foley is testing your sterile technique, and vital signs you have that pretty rigorous window that you have to be within 2 millimeters of mercury, 2 beats a minute with faculty. So be practicing that so that you are confident in your skills when you come in to do your test out with us. Okay, so today we'll do some practicing. You'll have time to practice your Foley. So I have the mannequin in the back set up so that if you want to practice Foley catheters, you certainly can on that mannequin. And then we'll have you practice vital signs. If two of you, we'll just kind of switch around. So we'll do a little bit of lecture today, then practicing how to dress a wound is what we're going to work on. Okay, so ladies at home, your skills videos are going to be super duper important for you to watch today. All of the videos under the skin integrity and the wound healing and in those skills videos are what you want to watch. Okay, and then when you get back to the lab, we'll practice a couple of those together. Okay, for Foley catheter, you know how when you put the Foley in the jelly to lubricate it, instead of putting it in the jelly, have whoever's reviewing, your peer or whoever you're with in the lab practicing, put the tip of the catheter in this soapy water. That way we're not getting any jelly. So just pretend you would put it in the jelly, and before you insert it into the mannequin, put it in this soapy water so that it doesn't get jelly on our mannequins. Okay, so I have that. This is a graduated cylinder. So if you're kind of wondering, how do I empty that Foley catheter? I found all of them. I couldn't find them the day that we were practicing. So I found all of them and I put them all by the bedside. So this is what you'll empty the urine into. It's calibrated so that you can see the numbers and how much you're emptying. Okay, so those are by the bedside. I did not put catheter stuff by the dude over here because he's kind of rickety. His head falls off a lot. So I just don't want you to mess him up any further, right? So that's why I don't have anything over there. Okay. Any questions as we move forward? All right. So you do have an exam on Wednesday. Any questions about that? I'll put the blueprints up today for you, so you'll know about that. So you'll have the test blueprint, so you'll know. Do you guys like it when I do that or not do it?
Yeah.
Okay, so I will do that again when I am done with class. Okay?
We have the test number 3.
Is
3 and 4 that were uploaded this weekend?
the blueprints were?
Yeah.
Oh, I already had it myself. Well, number 4 wasn't supposed to be, but I know number 3, so I'm sorry about number 4. But you have it ahead of time. How about that? So don't freak out about number 4, because number 4's exam, can you tell me the date you have it out? Emily, do you have anybody have their schedule out?
I think it's on the 5th.
Okay, so we have a little bit of time for that exam. Okay, so let's go over some more meds, shall we? Where we left off meds on Lasix, is that right? Or furosemide? So some of you need to figure out maybe a little bit different study plan on your meds. So I know making your own cards, but actually those cards, so if you could hold that up for me, Mo, if you study those cards and you study these sheets, that's what you need to study. These sheets tell you the definitions of a lot of the words that you may not know. That's why we're doing the definition sheet. So that's why I have you fill out those blanks, because it really is going to help you understand the words. But everything that I test about medications is on those cards that are meds 1 through 25. Okay. So the medication quiz that will be at the end will be all the meds. So don't stop studying the ones that we've already covered. Okay. All right. And we'll do another review game before that next quiz too. Okay. You guys have any questions? You can just shake your head. Okay. Okay, so I'm going to kind of stand up at the front of the room today so that these guys can hear me. Do you guys hear me okay? Loud enough? Okay, perfect. All right. Move this over here by Sammy. Nice mask today, Sammy. I like it. Okay, so Lasix, furosemide, is a diuretic, so that's a class. The therapeutic classification, diuretic. So a diuretic is a med class that removes fluid and electrolytes from the body through the kidneys. A med class that actually removes fluid and electrolytes from the body through the kidneys. There are lots of different diuretics, and there's lots of different kinds of diuretics. So this is a loop diuretic. So what that means is it's removing fluid and electrolytes through a specific part in the kidney, the loop of Henle. Okay? All right. So with your loop diuretic, you will want to monitor. So what is the nurse going to monitor and look for? I'm just going to kind of go over a few things. You want to look for your electrolyte levels, because it will get rid of all the electrolytes. Okay, so we want to look at our labs and make sure our electrolytes are normal. So electrolytes are going to include those things such as sodium, potassium, calcium, magnesium. I think you know all these. Chloride and bicarb. So what happens is you diurese. So you get rid of the fluid through your urine usually, and we can have problems with our electrolytes. So furosemide or Lasix can cause hypokalemia. So what's that?
Too little calcium.
Potassium. Yep, it's potassium. What is hypocalcemia?
Too little calcium.
Yes. So remember the K for potassium. Do you remember the K on the periodic table? So just remember hypokalemia, the K is for potassium. Okay, so it causes hypokalemia, hyponatremia, which is what?
Sodium.
Low sodium, and hypovolemia, which is what? Low blood volume, right? So hypokalemia, we will monitor that. We'll want to make sure that it is in the normal range. A lot of times when we give a diuretic, a loop diuretic, it's not sparing potassium. There are diuretics that are called potassium sparing diuretics. So we'll give potassium kind of hand in hand with this medication. It can cause tinnitus or ringing in the ears. It can also cause orthostatic hypotension because it can lower your blood pressure. So we want to make sure that we are having our patients change position slowly. Any questions about Lasix? I think the rest you can kind of read up on. We'll just kind of skim through these today since this is meds 11 through 15. So we're going over meds 11 through 15 first, Caitlin. Hydrochlorothiazide. So this is an antihypertensive, so med class that lowers what?
Blood pressure.
Blood pressure. It is also a diuretic, a thiazide diuretic. So hydrochlorothiazide is also, the abbreviation for it is HCTZ. So that's a big word to say, hydrochlorothiazide, right? So HCTZ, if you see that, it's the diuretic. So we can give it for two things, blood pressure and for a diuretic purpose, okay? So it's a thiazide diuretic, so it is going to be a diuretic that's going to prevent that sodium from being reabsorbed in that distal tubule of the kidney. It's really helping to prevent the electrolyte imbalance. So a little bit different than Lasix. So when you study a diuretic. You know, you have two different diuretics, two different classifications of diuretics, right? So you kind of look at the differences. So we know both of them are going to cause orthostatic hypotension. We know both of them are going to diurese and cause us to get rid of certain things, right? Get rid of fluids that we need to, okay? It also will lower blood pressure. So we need to make sure we're watching for hypotension, signs and symptoms of hypotension. With both of these medications, we always want to monitor intake and output, okay? So if we're not getting out what's going in, that's a problem, and we should be diuresing. So the whole point of it is to get rid of fluid, right? So always make sure you're monitoring I&O with these medications. We also are going to monitor edema with both of them. So a lot of times we give them to our patients who are having swelling in their legs. So we will have them actually take a diuretic to decrease the swelling, okay? Electrolytes, you kind of know, we just talked about that, can also be given for congestive heart failure. And we want to look for signs and symptoms of congestive heart failure. So edema, weight gain, crackles in the lungs, jugular vein distension, those are all signs and symptoms of congestive heart failure. All right, so that was 11, 12, 13. Moving on to, did I miss anything on your cards? Okay, good. Moving on to hydrocodone acetaminophen. This is a combo drug. So when you're studying this, you want to study your acetaminophen card in addition to the Lortab card, okay, the hydrocodone card, okay? So here are all the classifications. It's a antitussive. What does that mean? Yep, medication to reduce the cough. It's a non-opioid opioid analgesic, which is what part of this medication? The acetaminophen. And the opioid is what part? The hydrocodone, right. So it does also, this medication is given for mild to moderate pain. We want to make certain that we are assessing what prior to giving this medication. It's a CNS depressant. So what does it depress? What does that all mean?
Respiratory depression, heart rate.
Yep, respiratory depression, heart rate, level of consciousness is important with this one too. Okay? Yes?
Say someone's like on, if they're sleeping and they're like receiving a steady flow, would you still administer it to someone if they're sleeping or no?
Depends. If they're sleeping and it's like sleeping and not drowsy and lethargic from medication, I'd probably wake them if we have a scheduled dose to give. If it's a PRN, so if it's an as needed and my patient's sleeping, more than likely I would let them sleep a little bit, because if you're sleeping, you probably aren't in a lot of pain like you would be if you were awake. Does that make sense? So it's kind of like don't poke the bear. You need to use good nursing judgment. So if your patient has been complaining of pain, we finally got maybe some control and they're actually sleeping soundly, let them sleep and give it a little later. That's one medication that you can give a little bit later. One thing you do want to be aware of is the Tylenol dosage. So how much Tylenol can I give in a 24-hour period?
4,000.
4,000. So sometimes I give this Loratab and I give 2 of the Loratab. So a 5/325. So that'd be 650 milligrams. And if I'm giving that every 4 hours, I need to make sure I'm knowing how much Tylenol I've had in that 24-hour period. Make sense? Okay. So it can cause hypotension. It can cause bradycardia. You have a line there for bradycardia. Do y'all know what that means? Slow heart rate, what? Less than what?
60.
Less than 60. So Respir's normal respiratory rate is what? 12 to 20. So if we have Respir's less than 10, we need to do an intervention. So if you have a Respir, Kenny, you look like you're confused. But if your Respir's are less than 10, that requires an intervention. Make sense? Okay. So sedation, we want to always watch for level of consciousness with this medication, because if your patient is difficult to wake up, falls asleep during conversation, it may be because we've given them too much medication, otherwise known as snowed the patient. Okay, we don't want to do that. So if our patient's Respir's are decreased or we can't get them to wake up, we're using some painful stimulation, which would be like a sternal rub. We would give an antidote. So we would give the antidote for an opioid is called Narcan. Just an FYI, and we'll go over Narcan later. So you can, your patients can get a physical dependence with this medication, also a psychological dependence with the medication. So hydrocodone can cause that orthostatic hypotension. Gosh, a lot of medications have that side effect, right? So make sure that you are telling your patients to get up slowly. It can cause them to be drowsy, a little dizzy on their feet. So when you're ambulating them, it's a safety issue. So be careful of that. Question?
No,
Okay,
distraction.
perfect. Ibuprofen, moving on to the next one. Ibuprofen or Motrin, Advil, those are other names for this medication. So this is an antipyretic, so it reduces fever, or an anti-rheumatic. So that's a medication that's going to cause a decrease in the swelling in the joints and tissues caused by rheumatoid arthritis. It helps to slow joint destruction and it helps preserve joint function. You'll see this a lot of times in patients who have osteoarthritis too. They'll take ibuprofen or Advil to help. So it's a non-opioid analgesic, okay? It's an actual class called NSAID, so non-steroidal anti-inflammatory drug. So it causes dyspepsia. What's dyspepsia? Like upset stomach. So this drug you have to give carefully because it can help aid in starting a GI bleed, okay? So if you have somebody who has a history of GI bleed, you're not going to give ibuprofen to them, okay? So one thing that you'll want to monitor for, one of the side effects is a GI bleed, okay? It inhibits prostaglandin synthesis. We've already talked about that. We also give this, other indications would be for women who have PMS type symptoms, menstrual cramps, things like that. We give Advil, Aleve, Motrin for that. So dysmenorrhea is painful menses. Yes.
It says that for renal kidney, what would we be using?
So yes, it's harmful to the kidney as well. So you want to make certain that if you're giving this medication, you're giving it as directed, and you're giving it and looking at your kidney labs, all your renal labs.
So you shouldn't take it as a prophylactic.
Prophylactic for what?
Just not for an anti-inflammatory.
If you're not having any problems, you shouldn't take it. Yep, I would only take it. And that's the problem. This is an over-the-counter medication. It can also be given as a prescription too. We can give a higher strength as a prescription. So we can give ibuprofen 800 milligrams, and that's a prescription. But patients can take this over the counter. A 200 milligram tablet or capsule or gel cap is what it comes in, okay? So patients can take this over the counter, and it can be very harmful, especially in those elderly patients that have kidney impairment and they really don't know it. Or, you know, they've had some GI bleeds. They don't know all the side effects. So that's where you come into play and teach them really well the side effects and the implications that can be had with this medication. So, all right, Toradol. What one are we on? 16? Toradol's 15? Let's see. Okay, this is the last one for today. Ketorolac or Toradol, another NSAID. So we want to make certain that we have no GI problems with this medication. It decreases inflammation. It doesn't contain a steroid. So that's what NSAID means, right? It's a non-opioid analgesic. Toradol or Ketorolac is something that's given short term for pain relief. Okay, so short term, 5 days. We usually don't give it over that. Okay, so we can give it PO, IM, or IV. In like post-op, post-surgical, we'll give it IV. So we'll give them while they're, especially at the Dune Surgical Hospital where I work, we give it to them post-op days 1 and 2 for sure on a lot of our like total joints. So we want to make sure that we're testing liver function tests with this. So AST, ALT, assess platelet count. We want to make sure that they're not taking another over-the-counter medication, another NSAID like ibuprofen. What's another NSAID that we have talked about? What's the COX-2 inhibitor? Celebrex. So we want to make sure we're not like double dipping on those medications, okay? Any questions about Toradol? I think you can kind of read the other side effects and things like that. Those are the most important things. Questions? All right, moving on. Have a whole bunch of papers up here, sorry. Okay, so this is going to be a little bit of a review. So let me, ladies, I'm going to share my screen with you, okay? All right, can you see it okay? Perfect. Got to put my little clicker out. Okay, so this is going to be a little bit of a review for you, just because I do think that sometimes it is more difficult to understand all these wounds that we talked about. So we're just going to do a little bit of a review, okay? You guys can see the screen okay, Caitlin and Jade? Okay. All right, so remember that structure of the skin. Let me move them up. Okay, Structure of the skin. So we have, and you need to know this too for injections. Kathy probably went over this last week. So you need to know the structure of the skin so you know where your injections are going to. So you have the epidermis, the dermis, and then that subcu, that fatty layer, okay? We also have epithelial cells. They cover all those internal and external body surfaces. So what do? They help protect. They let things absorb. So like what would that be? What would you absorb? So we're talking about skin and absorption. What kind of things do we absorb through the skin? What's that? Sunlight. Sunlight, vitamin D, yes. So vitamins, good.
Like medication?
Medication, definitely. We absorb medication through the skin. Secretion, so we secrete, what kind of things do we secrete? Sweat, oils, things like that. So the sweat is a form of, we can sweat through diuresis, right? We can also sweat because we're having a fever, okay? So sweating. And then excretion. So those are all the functions of that skin. All right, so let's review, okay? So wound drainage. So we have serous exudate, so that's that thin, clear, watery plasma. So all of you have gotten like a scab and it's come off and it kind of seeps. Is that kind of, okay. So that's that serous exudate, okay? Maybe straw colored, and it's usually the acute inflammatory stage where that's at. The sanguinous is going to be bloody. So that's going to be pretty fresh blood right after surgery when you're emptying what's called this JP drain or this hemovac. You'll see different types of fluid in there, okay? So serous is the what? Then watery. That's usually when something's got healed a bit. But sanguinous is that bloody drainage, okay? Then days later after surgery, we'll notice that sanguinous turned to serosanguinous. So that's going to be a mix of bloody, watery, straw-colored fluid, okay? Purulent. Okay, what do we know about purulent?
Normal.
It's not usually a good sign, correct? So that's usually a sign of infection or high bacteria levels. So that's going to be that thick, opaque. So opaque means you can't see through it, not translucent. It's opaque. It's yellow and it's pussy. It's gross. We don't want that, okay? All right, so let's review our wound healing. So we have primary intention, which is where those wound edges, when you're describing this in your charting, you're going to say your wound is well approximated. So what does that mean? Yeah, they're together, okay? So the wound is well approximated. So a surgical incision is a great example of what primary intention would be. So the surgeon has closed this wound with sutures or staples and they are together. The edges are together, okay? So then we have secondary intention where those wound margins are not going to be well approximated. Usually this is when the wound is larger and we need to form that granulation tissue to fill in the gap. So what's that granulation tissue? What do we want it to look like?
Red and beefy.
Yeah, a beefy red, like nice red brown beef, right? That's what we want. It takes longer for a wound to heal by secondary intention, okay? And then tertiary intention is when that wound, that was previously opened is now closed. Usually this happens with large wounds that are contaminated or infected. So complications, we talked a lot about complications of wound healing. So hemorrhage is big, infection, dehiscence. Help me to understand what you know about dehiscence.
It's a wound that was already closed and now it's open again.
Yep, so it's closed and now open, okay? So dehiscence it can open and then it can bleed, which is not a good situation, let me tell you. You have a lot of people in there if that happens in your patient room. Evisceration would be what? What's the difference?
Viscera is coming out.
Yeah, so like your bowel, your abdominal contents are coming out through that wound.
Have you ever seen that?
Yes, I have.
Do people are they in shock when that happens, or is it
They
painful?
sleeping?
Yeah, it's usually painful. No, usually it happens because they've moved really quickly, or maybe that abdominal wound they've coughed and it's open and it protrudes. Yeah. So what do? What's your rule if that happens?
Sterile saline towel.
Yes, sterile saline towel. Put it over that.
So if you have a sterile towel, you can't like put it below your waist or anything, right? Like, or is there like a certain like?
Yeah, you want to keep it as sterile as you can. It's not the surgical environment, but you'll go get a sterile towel. You'll get it damp and you'll put it over.
Okay.
So.
Okay.
You can pick that towel up with non-sterile gloves. It's called modified. Have it be a modified sterile technique. So meaning kind of sort of sterile technique. And we'll talk about that a little bit today because that's what we'll do with a lot of these wounds. A lot of them are modified sterile technique. So, and fistula formation. So that's that where we kind of get like that cave. Another route for something to go where there wasn't a route, right? It's the road that we made that wasn't supposed to be there, right? Okay, assessment and documentation. So when you are going to be cleansing these wounds that I have on the mannequins today, you're going to do documentation. So you're going to either need your nursing book or need your computer up because there is examples in your textbook of how to document wounds. So that will be helpful to you. So if one of you has you can work in your pairs today. So if one of you has your book, make sure you're bringing that up so you know how to document it. So you're going to document the location, size, and depth, the color of the wound base. You always want to document the peri wound and describe any drainage or odor. So you didn't realize when you came to nursing you would use all these senses, right? So measure your wounds, just depending on facility policy, really. Wound pain, we want to make sure we are describing if they're having any pain. Before you do wound cares, what is one thing you want to do prior? Prior to doing any cares of the wound, what would you want to do with your patient?
Assess their pain level.
Assess their pain level and probably give them pain medication, depending on the wound, because the wound can be really it can be really painful depending on where the wound's at, how deep the wound is.
Hey, Courtney.
Yeah.
I'm being moved rooms right now, so can I log back in when I get moved to my other room?
You bet.
Thank you.
Yeah, you're welcome. See you later. Color of the wound base. So pale, pink. Is it pink? Is it red? Are we seeing granulating tissue? Which is what? Beefy red. Or is it yellow, meaning there's slough? Is it green, meaning maybe infection? Or is it black, that necrotic tissue? So if we have eschar forming on our wound, what is that? Yeah, dead. So can we stage that? If we have a pressure injury, can we stage something that has eschar on it? No, we can't. So we also want to describe the amount of tissue present. So for example, 75% black with a 25% red base. Okay, here's that eschar. So I can't see the bottom of that wound base, so I can't stage it. Okay. Slough. So slough, usually when I see slough, it is yellow in color. So you'll, again, document how much slough is present. So for example, in this, I would say that would be 90% slough. 10%, I can see a little bit of granulation tissue around the edges. Okay, so here's granulation tissue and slough. So hardly any slough here and this nice beefy red, okay? This has a little bit more slough, okay?
What's slough again?
Slough is kind of a protein-based tissue that's forming
So it's
to
not.
help in the healing
So
process.
it's not a bad thing.
It's not an infection. Slough isn't an infection. Usually slough comes off. It sloughs off. right?
If you were to document the slump on that one, would you say like 5%?
Yeah, 5%.
Okay.
This one, I would say 25%.
Okay.
And it really is pretty subjective, can you tell?
Yeah.
So that part is pretty subjective.
Okay.
All right, so we always want to document our peri-wound as well. So peri-wound skin, the wound edges. So is there that rolling on the wound edges that we'd want to notice? We want to note any edema. Can you guys see this picture here? This is on so tight that it has, really, I think it's a little too tight for the patient. So if you can see that ace bandage deep like that, probably have it on a little bit too tight. So we'll look at the induration, the hardness, the area of hardness, we would measure that, the erythema, the redness, and then any maceration that might be in that wound. So we kind of know the difference between abrasions and lacerations. So an abrasion is that excoriation or wearing away of the upper layer of skin, usually caused by friction, riding a bike, rollerblading, walking, fall, skin your knee. Okay, that is an abrasion. So laceration is actually where we actually, there's a cut and it goes through the surfaces of skin, fat, and muscle. That would be a deep cut, right? So we can then fix the laceration. The abrasion, we really can't because we don't have edges that we can bring together, right? We can't get those approximated. But lacerations, for the most part, we can probably put them back together.
Do nurses do stitches?
No.
Okay.
Well, it depends. Let me tell you a time when you could. So I worked for a plastic surgeon and I was his first assist, his nurse first assist in the OR. And so he taught me how to do all these stitches. So I did do suturing, but I had to be trained first. So that took special training and I had to get what they call privileges. So I had to get surgical privileges to go to each of the facilities to work with him. So yeah, I do know how to do a running stitch. I know how to do a subcuticular stitch. I can do stitches that are, first you stitch the underlying tissue and then the skin. So I got taught a lot of cool things when I worked with him.
Nurse or doctors do stitches?
Mm-hmm. Like what do you mean by that?
I remember I went into the doctor. I cut my hand open because I was being stupid, and
Yeah.
they had someone put it open, but I thought it was a nurse.
Yeah. Usually a nurse does not do stitches. So the provider will. So these are just different stitches that you can do. An interrupted where you would kind of loop it and tie it each time and cut off the string. This you start at the beginning and you just kind of run through. It's a running stitch. You never stop till the end. And then your subcuticular, which is actually putting together the subcutaneous tissue first and then that top layer.
Is there
So
a
those are dissolving stitches.
Is there a reason for like each one? Like the first one was used that for a certain kind of cut, the interrupted?
It kind of depends on the surgeon too. So like the surgeon I worked with, he felt that you could get a better scar. So part of a plastic surgeon is always looking at how do I get the best scar. So he thought we could get a better scar doing a running stitch on some of those. Whereas it just depends on the physician too. So some providers don't do this very often. So they'll do an interrupted stitch every time. Some don't even like to do stitches, so they'll do staples or glue, right?
How come we can't do stitches?
It's not in our scope of practice. Unless you do something like I did. So unless you get trained. It's kind of fun. You get to take them out. So that's good. But one thing you need to know is what kind of stitch you have here when you take it out. Because with these, you have to pull out every little stitch, okay? With this, you could just clip the end and pull it out. Make sense? So, and that subcuticular, that will dissolve underneath the skin first, and then we put another suture on top. Okay, ecchymosis. So that's that reddish, bluish, purple discoloration of the skin. caused by those capillaries underneath that broke and blood is accumulating in the area. We sometimes call this a bruise. We always call it bruise, right? Before you came to nursing school, or a contusion. So it can be interchangeably used with the word hematoma too. So just depending on where you're at, what you're doing, just knowing what this looks like too. So this looks like maybe a sprained ankle. So you'll see a lot of ecchymosis on a sprained ankle. Okay, so hematoma, localized swelling filled with blood, results from a break in the blood vessel. So you can see there's different types of hematoma. Can get a brain hematoma as well. So how would you get that? Probably a fall. That would be a common cause. Okay, here's those great little, I know you like real good pictures, right? So here's, love it, good. So you have evisceration here, okay? And then these are dehiscence.
What is that?
Bowels.
Left. Is that the left picture on top?
I think that is an abdomen because this is a belly button.
Oh, okay.
And that's why we instruct our patients to do splinting. And we also will give them, sometimes if they have a big abdominal surgery, we'll give them what's called an abdominal binder. So we actually kind of split, helps to support that because those muscles have been cut through. So you need extra support. So you encourage them to do splinting, which is holding on to a pillow, kind of holding on when they do some coughing and deep breathing. And that's really important to do when you are post-surgical patients. So gross, huh? Okay, wound dimensions. So we always are going to measure length and width and depth. So we're going to use it like a clock. So the head is at what? 12 o'clock, right. Is there tunneling? Is there undermining? And we'll always do our measurements. There's a tunneling and undermining. I have a couple of videos for you to watch about that, like this one.
What are the 7 steps of effective wound management? Why is each step important? And what happens during each one? Knowing the answers will help you develop and support the most effective treatment plan to promote healing. Let's take a closer look at the role of each step and how it's typically performed by a clinician, such as a certified wound care nurse. Wound assessment is the first and foundation step of proper wound management. The goal is to identify and address all issues that may impact and potentially delay healing. This will help guide the development of the most effective treatment plan, in keeping with the healthcare provider's established wound care guidelines. To perform this step, inspect and evaluate the wound based on several characteristics. Start by identifying the location, length, width, and depth of the wound.
So these are
Then
important
check
for you
for
to know.
undermining, which is a rolled over lip around the wound. Also check for tunneling, which occurs when the wound burrows under the skin. Next, look at the exudate for drainage color, odor, amount, and consistency. And examine the tissue appearance for color and moisture level. Is it wet or dry? Another important characteristic is the peri-wound, which is the area surrounding the wound itself. Is the peri-wound intact or macerated, which means shriveled skin caused by
These are
prolonged
all good
moisture?
words that you'll want to
Then,
know.
examine the
You're
wound for
documenting.
infection and bioburden, which is the state between normal and infected tissue. Is the wound red, a condition called erythema? Is there swelling, known as edema? Is the wound warm? Does it have an odor, or does the patient have a fever? Lastly, what is the patient's level of pain? By assessing all of these wound characteristics, you'll be in a better position to develop and implement the most effective treatment plan and move on to the next step, cleansing the wound. Cleanse and irrigate the wound per its assessment. Cleansing and irrigating the wound creates the optimum environment for healing in 2 ways. First, it removes loose debris, exudate, pus, and free-floating bacteria. And second, it supports the wound assessment by making the wound easier to see and evaluate. To cleanse the wound, swab it with dampened gauze or a similar product and irrigate to remove deeper debris. Step 3 is to protect the peri-wound from wound drainage that can cause maceration and skin stripping. Protecting the peri-wound skin is also essential because it helps prevent the wound from increasing in size. But this can be a challenge because peri-wound skin can appear normal. As a result, protecting it can be overlooked and damage can occur. To protect the peri-wound, clean it with a normal saline solution, then apply a non-alcohol-based skin prep solution. Next, fill any depth in the wound by packing all open spaces with the appropriate filling material. This step is important because it helps prevent pockets of abscess from forming, as well as promotes healing. Wounds that require filling include tunneling wounds, undermined wounds, and stage 3 and 4 pressure injuries. Fill them based on the wound assessment, the wound's contours, and the clinician's discretion. Choose from gauze, foams, fibers, alginates, and gels. For infected wounds, add an antimicrobial agent. After filling the wound, apply a protective dressing to cover the wound. The goal is to maintain a clean, moist wound bed, which promotes granulation, healing, and closure. Properly covering the wound also helps prevent infection while the wound is healing, and until healthy skin can resume its infection-preventing role. If the protective dressing doesn't secure itself, apply a secondary dressing. This step helps promote healing by protecting the wound from pathogens. Securing the dressing also secures medical devices and aids in patient mobility. Select the most effective secondary dressing based on provider policy and procedures. Examples include gauze, conforming stretch bandages, tape, transparent film, and composite dressing. These products attach to, cover, or pad the protective dressing and help ensure it stays in place. The final step is to evaluate the wound's healing progress when you change dressings. Is it healing, regressing, or is there no change? Knowing this is important because it can help you determine if the treatment plan is succeeding or if another approach is required as soon as possible to promote healing. To evaluate the wound, ask yourself, are there any new signs of infection, such as a change in color or odor? Are the protective and secondary dressings staying in place? And if applicable, is the drainage control working? To help promote healing, know the 7 steps of effective wound management. Assess, cleanse, protect, fill, cover, secure, and evaluate.
Know the 7 steps when you
To
are
learn more, visit cardinalhealth.com.
assessing. Any questions? All right, so here it is again. I know you missed it. Taco. So, wound drainage, type, amount, consistency, and odor. Taco. Okay? Did you think of this when you had tacos on Tuesday? You have tacos on Tuesday? Okay. So, again, you need to know your wound drainage, so that's why it's on here once again. So, serous, moderate to heavy amount of serous exudate can mean that there might be an infection. But in the acute inflammatory stage, that's normal to have quite a bit. Sanguinous, you know what that is. Serosanguinous, I kind of changed the color of the font so that you could recognize. It's a little bit lighter. Purulent, gross, usually. Means infection or high bacteria level. Okay, so amount. When you're assessing, when you evaluate, so that last step really is probably your first step because you're evaluating it once you take that dressing off. Okay, so last step of the process, but you'll evaluate too when you take the dressing off. Okay, you want to evaluate the amount of drainage. So none, scant, small or minimal, moderate, 25% to 75% of that dressing is going to be saturated, large or copious. So wound tissues are filled with fluid. It involves more than 75% of that dressing. Okay, so you need to let me know how much drainage, the amount of drainage that is. The type The amount, the consistency. Is it thin? Is it runny? Is it thick? High viscosity. That's that picture of the honey again to help you remember. Odor. So is there any odor noted? Is it strong, foul, pungent, piquant, musty, or sweet? Use those appropriate terms. So you want to use these terms when you're describing the dressing. Is it dry, moist, saturated, or leaking? If it's leaking, we'll definitely need to change that. If your dressing is leaking and it isn't time for the dressing change, what do we do? Right, exactly. All right, here's another video for you. Assessing and the wound and obtaining measurements. So this is a really good.
In this demonstration, we will be exhibiting the correct measurement of a wound. For wound measurement, you will want to have a disposable paper or similar measuring device. The measuring device is either a paper or plastic disposable measuring tape. It is generally marked in centimeter markings with sub-markings in millimeters. A cotton tip applicator is useful for measuring depth and checking for any undermining. This model demonstrates a wound. By convention, the superior aspect of the wound would also usually coincide with the head, and the inferior aspect would be the foot. We measure length from a head to foot direction, and width is measured from left to right or right to left. Depth is measured the maximum location of depth in the wound. The left to right or right to left convention does not matter in terms of the documentation. It is important, however, that length and width are correctly measured and documented, as the convention from head to feet for length and left to right to width are important in being able to reproduce measurements between measurers. In this particular instance, we would start off by measuring the wound in the length dimension, where there is the maximum length of this wound of approximately 5.7 centimeters. The width would then be measured at its maximum point of width, which is 2.5 centimeters. The depth we then would determine by probing the wound with our cotton-tipped applicator using the cotton end. We would probe all areas of the wound to determine where the most depth was located. It appears to be approximately in the middle of the wound. We then slide our finger down the cotton-tipped applicator to where it is flush with the intact skin, pinch the applicator at that point, and withdraw from the wound. This can then be laid over your measuring device and the depth determined. In this particular instance, it appears to be 1.8 or 1.9 centimeters. Once the length, width, and depth of the wound has been measured, it is important to then record any evidence of undermining and what the dimensions of that undermining are. In determining undermining, gently probe the wound with your cotton-tipped applicator circumferentially around the wound. You can see that over on this side of the wound, we are starting to see some undermining. It appears that at this location, the cotton-tipped applicator slips deeper under the wound than it does at any other point. This would be the maximum area of undermining. As you can see, by convention, the superior aspect of the wound, or the head aspect of the wound, would be 12 o'clock. If we then progress clockwise around a clock face, the area of maximum undermining is approximately 10 o'clock. Similar to how we measured the depth of the wound, you would want to slide your finger down the cotton-tipped applicator, pinch it with your nail, and then bring it up to your measuring device. In this particular instance, it appears that the undermining is approximately 1.7 centimeters. As you will recall from the last image, the undermining is located at 10 o'clock. This would be recorded as 1.7 centimeters of undermining at 10 o'clock.
So when you're doing a depth assessment and tunneling assessment, I would wear sterile gloves for that. I don't know if that's what you were going to ask.
Oh, I was gonna say, do we use the same Q-tip to check everything, or do you have to change it out? Like when you're checking.
I would get a different one. So They're sterile, so you would open it up or have somebody helping you, or open them up ahead of time and use that make sure that you don't get that tip. Again, it's a modified sterile technique. So, okay, so your assessment, remember we have that focused skin assessment. You need to do a Braden scale on anybody. That's part of your skin assessment. You'll do a Braden scale assessment on your patients every shift. So get used to it, right? If it's rated less than 18, they're at risk. So remember, that's the opposite of the Morse-Fall scale. So the Morse-Fall scale, if the higher the number, the higher the risk. Okay, so they're the opposite. I hope that helps you remember that. Remember, Brady's low. Okay. We'll always do initial and ongoing assessments. We cleanse and irrigate to remove any debris and exudate, so drainage, kind of like what they showed in those videos. We usually use just a normal or a sterile saline solution. Some physicians do have special solutions, like a HibaCleanse solution that they'll want you to use, but it will specifically say in the orders what you're supposed to use. And you know, we have lots of different dressings that we can use, and we'll go over some of those today. Another dressing is a vacuum wound vac. So that's that vacuum assisted system. So think like a nurse. We're going to do this. I have it actually on a paper, so we'll come back to this. This is all on a paper. Remember when I said you get 5 points for that brain scale activity in class? Today's the day. Lucky you. So nursing intervention. So what do you as a nurse do when you have wounds like this? You cleanse and irrigate. You care for any drainage devices that you may have. And I actually have a couple out here so I can show you. These are in the patient. So patient with an abdominal wound. Ooh, let me get it together. Let me get over here. The people on Zoom could see this. So you have an abdominal wound. This will be the drain that would come out. So this is preventing from fluid accumulating in the area of where they did surgery. Okay, so this would be the tube to the drain. Okay, a lot of times it's secured with a suture. So when the drain's ready to come out, you would clip that suture and you pull the drain out. So inside the patient, this is a long drain. This is a JP drain, okay? So JP drains are used a lot. Sometimes I've had 4 or 5 JP drains on one patient, okay? So this is a JP drain, and it is, when it's compressed like this is compressed, okay? So the air is out of it. It looks like a little grenade when it's not, right? Okay, so as it fills with bloody fluid, it will open up, okay? And when it fills like that, we need to drain it out, okay? And how we drain it is we open that up and we squeeze it into a little sterile cup and we measure it. We measure all the output because most of the time you're not going to get these drains out if there's a lot of fluid draining out of them, okay? And then this just clips to the patient. So these are their little friends while they're post-op usually, okay? So it is your job to make sure that they're drained and that you're assessing what type of fluid is draining in this JP drain, okay? So abdominal surgeries, you'll see this. Neck surgeries, you might see this. So I had a patient who had a neck tumor and had a JP drain in his neck so that the hematoma wouldn't form there, okay? So draining these, keeping track of INOs is really important, okay? When you take them out, you always make sure anything you take out of a patient, you make sure the tip is there. So you want to make sure that tip is intact, okay? So when you take those out. This is another type of drain. So same thing, the tube would be in the patient. Usually it's not a bifurcated tube like this, it's just a single tube that looks more like this JP tube. So this is called the hemovac. What's kind of funny on this one is these hemovacs, at the Dune Surgical Hospital, on the front of them, it says Jackson Pratt, which is kind of confusing because this is a JP drain, okay? But this is a hemovac, okay? So you'll see springs in there. See those springs, okay? Those springs, we compress it flat as a pancake, okay? We want it compressed so that it fills with fluid, okay? So when this is full, we have to drain it. How do we drain it? Same as a JP. I always tell students, please pull away from you because you will get blood splattered on you. You'd always drain and take care of your tubes with gloves on. And then you just pour it into the container and measure it. Okay, usually there's containers and each container is marked. So if your patient has multiple drains, the containers will be marked with numbers. So they'll number the drains and they'll number the containers so you're not cross-contaminating anything. Okay, yeah.
So those containers just like sit in the room and you just use the same one and just
Yeah.
fill it up?
Yep. I leave them by the bathroom sink. So those containers that you drain all of your fluids from, they're usually just sterile urine cups and they're not sterile after you use them the first time. But then I will measure, throw the bloody drainage usually into the toilet and then rinse it out in the sink and then rinse my sink out.
Oh, okay.
Yep. So it's kind of, you take a couple, if you have a patient with 5 drains, you would take a couple to the bedside, drain out those drains, take them, do your recording so you don't get it all mixed up because that's a lot to keep track of. So usually we can take these out. So rule of thumb for most surgeons would be 30 mLs in a 24-hour period. So if they're draining less than 30 mLs in a 24-hour period, we can take these out. Some people get sent home with a drain. So some people have to go home with their little friends. They don't much like it, okay? So you do have to teach them too that it's important when they're caring for their wound that this gets in my way, that they're caring for their JP wound area too. So where that drain comes out, we need to do cleansing there. And we need to put, usually we'll put a little dressing over that too, because sometimes it does leak around the edges. So when this comes out, there's a hole where that drain was. All we do is cover it with the dressing. And I just make certain that my patients, they can never shower or bathe when they have drains. So we can sponge bath them and give them a bed bath, but we can't have them immerse into water. And even when they get this out, or when they have a dressing that needs to be done, or if they have an incision, no tub baths, okay? No tub baths. It's really important.
What happens when a patient has a drain for too long? Does that ever happen?
Not usually,
Okay.
because they won't let it go too long because they don't want a risk of infection.
Okay.
So, good question. Any questions about drains? They're kind of cool. I don't know where this goes, to what mannequin this goes, but it was a good visual, right? I gotta find my clicker. Okay, so caring for your drains is going to be really important. And in surgery is usually when they debride the wound, so they get that taut, sometimes really infected tissue, sometimes just slough. They'll debride it so that they get that granulation tissue forming instead of the tissue that we don't want.
So is the surgeon one who inserts the drain then?
Yep, they insert it at the time of surgery. So when they get out of surgery, they already have the drain. You're the one that takes it out though, so that's cool. Assessing the wound again, location, size, appearance, drainage, redness, swelling. I wanted to talk to you a little bit about those pressure injuries. So remember, did we talk about Mepilex dressings last time? Okay, I'm gonna see if we have a Mepilex. So Mepilex dressings are dressings that actually help prevent if we don't have a patient. So we do. Okay. So again, pressure injury is something we really want to prevent, right? So this is a Mepilex dressing, and I can pass it around. This one would be good for a heel, okay? So there's a padding on it. So you can put it on when you see maybe some non-blanchable skin, so something just starting to happen. You can put this on, or you can put it on for preventative measures. So there is a heart-shaped one. It doesn't quite look like this, but it kind of that is for the lumbosacral region. So that coccyx area, you can put it there, and it's kind of a heart-shaped. And a lot of times I'll put that on preventatively, or put this on the heels or on the elbows, okay? These Methylex dressings can stay in place for 3 days. So when you do your assessment, you pull back the dressing and then you put it back on the patient. So when I worked at Unity Point, the policy was if there was a smiley face outside of this, so you always date and time and put your initials on any dressings. So if there was a smiley face on this, this meant whatever underneath was good tissue. There wasn't any breakdown. If there was a sad face, it meant that there was breakdown, okay? I don't know how all facilities do it, but you guys can pass this around. That's a Methylex dressing. And hopefully that will help prevent pressure injuries. They're really expensive, but in the end, it's a lot less expensive to put a Methylex dressing on your patient than it is to treat a pressure injury that's caused from them being immobile or in the hospital. All right, a day in the life of the wound nurse. We'll watch this video and then I'll let you guys take a break.
So last time the measurement was 1.5 centimeters and now it's 0.6 centimeters. So that's more than half that it reduced in size. Isn't that great?
Coming to wound care is definitely a process. Usually we let them know on the first visit that the physician is going to want to see them on a weekly basis. That's how we track the progress, make sure that the treatment that we're using is working properly. So 0.6, and when they come every week, we can assess the wound, we can do measurements, we can test for infection, we can see if there's any other testing that needs to be done that we haven't done yet.
Wound care is indeed a specialty. It is a comprehensive, robust system of how we're going to look at the patient. Do they have any other health problems that go along with their wound? Are they diabetic? We have people with vascular disease that come in. So you're not just treating the wound, okay? You're treating the whole person. So we need to understand their whole medical history, what kind of medications they're on. So a lot goes into treating that little cut or whatever wound they might have. The demographics that we treat can range from 18 years all the way up to, I think our oldest patient was 103. So it really it varies. So you don't know who's going to walk in the door and what they're going to walk in the door with.
So normally you hurt yourself, you throw some Neosporin on and a Band-Aid, and then 30 days later you realize this is getting worse or it's not doing anything. So that's when you come to us and we can find out exactly what the problem is. Is it a circulation problem? Is there an infection that needs to be treated? Is there a special topical treatment that we need to do? Is there swelling that's contributing to the wound not healing? Those are things that we look at that a lot of like primary care or such doctors they don't know that that's the route that we take.
That little ulcer that's on your foot, there's so many other things that we have to do to heal it. We have to offload it. We might cast it. So the patient's like, wow, I have this little tiny ulcer on the bottom of my foot, but I'm getting the cast put on. Why are we doing this? So we kind of have to educate them and explain what goes all into it and what they need to do from their side to heal it. We have a great group of nurses here. They are wonderful. They are really passionate about what they do.
We all work together great. A lot of the patients know us by name, and we know them by name. We know their families, we know our families. So
we got a whole wide array of different skill levels, but all of the nurses are wound care trained, and they continue their education. We promote continuing education, so we stay up to date on evidence-based practice.
So we're always learning together, physicians, nurses, patients, the case managers, we're always learning and finding new ways to improve nursing, especially wound care.
It takes a long time to heal a wound sometimes. Sometimes they'll be treated in a couple weeks and they'll be done, and they'll be grateful they're done and they don't have to come here anymore. A lot goes on the patient's shoulders as far as healing the wound. They have to keep their legs elevated 30 minutes a day, 4 times a day. They have to wear a cast or wear a special offloading device to treat the wound. So what they do will dictate how long their wound is going to take to heal as well.
It's nice to be here and kind of see patients on a weekly basis and see results, actually. See people heal and see people leave with a smile, and everything's good.
Wound care is a totally different nursing field. You're having patients come in and you're seeing them every week. You're building that relationship and that trust. And it's a great place to really build nursing skills.
You always see something new here, so it's a great opportunity.
So you can actually become, so once you're a generalist RN, and that's what you'll be when you graduate, you can actually specialize in wounds and get a certification for being a wound nurse. So go ahead and take a break.
When is Mr. Deck?
What's that?
When do you want us?
5 minutes, how about that? All right. Did any of you come in this weekend and work with the senior students?
No, I had a meeting that entire time.
Okay. Anybody worked with a senior student at all?
Me and I worked with Annie Betts for like a minute
Okay.
when we came in to practice our injections.
That's kind of what they're here for, to help you. And if I see you struggling even on exams, I may recommend that you come in not to use them for the skills lab, but to help you study. So remember, they're here on Thursdays and Sundays, Thursday nights and Sunday afternoons. So that would be really helpful.
What time Thursday nights?
I think it's like 5 to 8. So is that a bad time for you? So Thursday nights, but also Sunday afternoons from 1 to 4.
Actually,
So,
that evening.
all right, sorry. Forget about this little thing. Okay, so let's review. Let's list 5 ways the nurse can independently and collaboratively prevent a pressure injury. So 5 ways. What are some ways that the nurse can prevent pressure injuries? Inspect the skin. Yes, definitely. So that's an independent. Positioning. How often do we reposition our patients?
Every 2 hours.
Every 2 hours. So she talked about too, that nurse, the wound nurse, talked about offloading. What does that mean?
Put pillows to like, so there's like if they're
Taking the
laying-
pressure off. So like putting pillows underneath your legs so that your heels aren't rubbing on the bed, or same with your elbows, right? Okay. What are the things? Bandage. So the Mepilex, we can do a preventative Mepilex.
Manage.
That is in nursing. You don't need an order to put a preventative Mepilex on. Okay. Fluids.
Manage moisture.
Manage moisture. What other with moisture is great, because what does moisture do to the pH of the skin?
Lowers it.
Changes that pH, so it's more prone to breakdown. Okay. On the lines of nutrition and fluids, what do we want to do to help? What can the nurse do? High what? High protein diet. Yes. What is that going to do?
Speed up wound healing.
Yep. What vitamins did we talk about?
C.
Zinc, vitamin C are good supplements. So, good. Your wound nurse, if you have a good wound care nurse that's working with you, she'll be on you if you don't document the amount of protein in a diet that they're getting with each meal. So that's a part of the documentation process. At Unity Point, they actually had percentage of protein in the documentation.
So like, because we get hospital meals and stuff, does it say? Because like I can't look at a steak or like a chicken and be like, yeah, that's 5 grams or whatever. Does it like say in the thing?
Well, they will have, yes. I mean, you could go and get that, but usually it says, you know, how much a meal was consumed. You know, 50% of protein was consumed. It wouldn't be any more specific than that.
Okay.
Yeah. So don't worry. What collaborative things can you do? So what does collaborative mean? Working with the patient, but also another provider, right? So maybe you're going to be working with social work. Maybe the home environment isn't good. Maybe it's that quadriplegic patient that was living in a hotel, homeless. So you would do some collaborative interventions, right? So collaborative may be working, you have a diabetic patient who has a pressure injury. We may work with the dietitian because their diet is poor, okay? Make sense? So what are the stages of pressure injuries? And don't just tell me numbers, I want to know specifics. So I want you to use your resources and we're going to go over the stages of pressure injuries. Kathy has my sticks too. She's got everything in mind. You're right, name on that. Yeah. Here's a new stick. I'll give Kathy her own sticks. You guys would write your name on the sticks. Your pressure injuries are all in your Davis basic nursing book. There's a whole table of them. That'd be the best way to look for them. Can you go into the search and put pressure injuries? Did it come up? Write your name on the sticks so I have sticks. Oh no. This is what I get for handing out sticks again. Write your name on your stick. Oh, sorry. Thanks, Jules. Thought it was the same place I said it. Right, one. Alright, got a slipper. How was volleyball, ladies? Does it? Did you blow out the water? Okay. So stop talking now. That's good. That's good. Good, you had fun. That was amazing. Ooh, look at you. Did I give you two?
Yeah.
So you can.
Oh, boy.
I'll throw one out so you don't have to answer twice. Look, you got to write your own today.
Are we gonna see Kathy this week or?
I don't know. I'll let you know more when I know more. How about that? Should we go forward? All right, Sammy.
Stage 1 is non-blanchable,
Non-blanchable skin. Okay, so what part of the skin does it affect?
just the top
Which is what?
dermis or epidermis.
Yes, epidermis. Okay. All right, Kenna. You're telling me about stage 2.
About stage 2?
Yeah.
So it's partial thickness loss of the dermis. So it's starting to break through the skin. It's open and shallow. There was no flaw. Maybe impact or open, like a blister
Lindsay.
Okay, stage 3 is a deep crater characterized by full thickness skin loss with damage or necrosis of subcutaneous tissue.
So stage 3 is going all the way into the subcu. So stage 2 is a dermis, epidermis. Stage 3, dermis, epidermis, subcu. Okay. Stage 4. Well, that person's not here. Caitlin Tooley.
Stage 4 is like damage to the muscle, you can see bones or tendons, and it has self or scar and
Okay. So the SCAR isn't covering the entire wound base though. So that's the difference, okay? Okay, what do we got next? Emily Stanek.
I'm not gonna lie, I don't have the last.
Do you have your book, F.A. Davis book online?
Oh, yeah.
Oh. Borrow your friend's book, but yeah, you can look it up online. But here's stage, last stage. Stage 4. Oh, so the last stage is what? Unstageable. So there's stage 4. You have deep tissue injury. And then here's unstageable. So tell us about unstageable. You guys all remember? What about unstageable?
It's covered.
Full thickness. It's all SCAR. So you can't even see the wound. So we can't give it a staging because we don't know. Can you see the tendons and the bones? Can you see the subcu tissue? No. So it's unstageable. Good. Thanks for the review. All right. I know a lot of you don't have the skills videos. Am I correct in saying that? Yay or nay? You all have them and you've been watching them? I have them. You have them? I have them too. So I have them pulled up, but gracious. Okay, here they are. So in your Davis Plus, you have the nursing skills video. It's online streaming, and we're going to go over a few of them because I have 4 patients set up for you that are going to need dressing changes. So I'm going to hand these out to you. So this will get turned in. You're going to document what the wound looks like, your wound assessment. So that's where your textbook is going to come in handy because there are documentation examples in there. And you'll also need to look up Mr. Harmon. He's the your patient at the beginning of your chapter. Here's a Braden scale for you all. We're going to give a rating of a Braden scale to Mr. Harmon, William Harmon. He's your patient. Yeah, please don't be that. And everybody at the end of this row. Okay, so obtaining a wound culture by swab is the first one that we're gonna watch. These are really short. And so because some of you don't have them, I thought it would be easier for you to watch up here than for us to kind of try to gather around. So if you guys cannot see well, make sure that you get to a spot where you can see. So they're really short videos. Now it's telling me I'm not logged into my account. There's also procedure checklists in there, which is kind of nice. Okay, so we have a little cart, and I'll show you that cart here shortly.
When performing the procedure, always identify your patient according to weight. Place the patient in a comfortable position
We'll skip
that
that
provides
first part.
easy access to the wound and will allow the irrigation solution to flow freely from the wound with the assistance of gravity. Place a water-resistant disposable drape between the patient and the bed to protect the bedding from any possible runoff. After performing hand hygiene, don gown, face shield, and clean non-sterile gloves.
And we have goggles and a mask in our cart. Why do you think she has all
Remove the
that garb
soiled
on?
dressing.
Want contact with it?
Yeah, in case it splashes, she's gonna get a. It's a methylex dressing.
Dispose of gloves and soiled dressing in a biohazard bag.
Always change gloves
Again,
after
perform
you
hand
take
hygiene.
your deal.
Then don clean non-sterile gloves.
Don. Give the Don.
Place an emesis basin at the bottom of the wound to collect irrigation runoff. Avoid touching the wound with the basin.
This is sterile urine cup. Ours aren't sterile anymore, but we have urine cups in our cart. Just making sure you're not touching the inside or the cap of that. And when you pour, you don't want to touch the outside rim of that sterile container. So watch how she pours. You always pour out the first part into the garbage. That's what she did there.
Using a 19-gauge angiocatheter, remove the metal stylet needle and dispose into a sharps container.
That's just to get the right amount of pressure. We don't have an 18-gauge angiocatheter, so we could just
Attach the angiocatheter to a 35 milliliter syringe and fill with normal saline irrigation solution. Commercial irrigation kits containing a piston-type syringe may also be used.
So first she cleanses it. before
Putting
she
the
puts it.
angiocatheter tip 2 centimeters from the wound bed, gently irrigate the wound with a back and forth motion, moving from the superior aspect to the inferior aspect, or from clean to dirty. Dispose of the emesis basin. Dispose of the syringe and angiocatheter in the sharp disposal container and gloves in the biohazardous waste receptacle. Obtain an aerobic culturette tube with calcium alginate or rayon swab, not cotton tip. Twist the top of the tube to loosen the swab. Don clean, non-sterile gloves and locate an area of red granulating tissue in the wound bed.
Where do you think she can find that? The whole wound bed? Strangulated.
Withdraw the swab from the culturette tube. Press the swab against the granulating area with sufficient pressure to express fluid from the wound tissue and rotate the swab using a rolling motion.
What are we doing? Why are we getting a swab? What does it do?
Swab the wound from margin to margin in a 10-point
Think about
zigzag
it.
pattern, avoiding contact with the wound edge.
Nope, that culture is actually gonna test for any bacteria, for
Do
whatever
not allow
is
the
growing in
swab
there.
to touch anything other than the granulating area of the wound. Avoid wound edges. Do
So
not
the
swab
line
cultured
technique is
areas where
rolling
SLU or eschar is
And
present.
the Z trap.
Do not roll the swab around in a pool of exudative material. Do not swab multiple sites with the same culturette. Use more than one culturette if several areas need to be cultured. Carefully insert the swab back into the aerobic culturette tube, making sure it does not make contact with the opening of the tube upon reinsertion. Twist the cap to secure the tube. Crush the ampular culture medium at the bottom of the tube. Note, inspect the culture tube to determine whether this step is required. In some systems, it is not. Label the culturette tube with the patient's name, patient identifier, birth date, source of specimen, and date and time of collection.
A lot of glove changing in hand technique, you noticed?
If there's swab, do you get that in the sample or do you avoid it?
You try to get the granulation where there's granulation tissue.
Apply clean dressing to the wound as needed.
Make sure you dry the peri wound before you put your dressing back on. Number one, so it sticks, but number two, so there's not moisture and maceration happening. So modified sterile technique with this is keeping those dressings sterile, keeping that culturette sterile. The tips of the angiocatheter in that sterile urine cup should all be sterile.
Arrange for transport of the specimen for culture to the lab immediately. Do not refrigerate the specimen.
You have somebody pick it up. So there's usually like a little area at the nurse's station that your transport people will come to get those samples for the lab. But you need to make sure you're calling and it's not sitting out, because if it's sitting, the sample might go bad because it didn't get tested right away. Especially like urine, you can't leave urine sitting out, things like that.
When you finish the procedure, remember the universal steps that apply after all procedures. For example, leave the patient in a safe, comfortable position with a call device in easy reach.
to determine this wound requires sterile technique. After removal of soiled dressing, apply sterile gloves for irrigating, obtaining culture, and applying new sterile dressing. What if the culture tube is not sent to the lab within 72 hours? If the culture swab is not sent to the lab within 48 to 72 hours, it must be discarded. Be sure to check the policy within your institution. What if the wound care and culture supplies are kept on a common treatment cart?
Like that.
Common treatment carts should be left in the hall and not taken into individual rooms.
So Unity Point has a common treatment cart. So the Dune Surgical Hospital has a common treatment cart. So it stays out in the hall, so you just wheel the cart, and right outside of the patient's room is where you would leave all of your supplies so that you're not contaminating them. Okay, so your patient, let's see, dry dressing. Your patient halitosis is going to be a wound culture. So Hal is right here. Here's Hal. And I have a checklist for you. So this will be the checklist. So you're going to be in your partner groups and you're going to use the treatment cart, gather your supplies, and do just what they did. Okay? And we're going to just rotate. So once you're done in that, with that particular dressing change, you'll rotate to the next one. Okay? So there's 4 different dressing changes that we're going to do. All right? So that was the first one. Yes, Kayla?
Kate looks like she can't hear you.
Huh. Does she have herself on mute? Can you hear me now? Jade, can you hear me?
I can hear you just fine.
So let me chat with her quick.
I can hear now. I put headphones in. So I don't know what's going on, but that it works now.
So the first thing we're doing, Caitlin, is we are going over videos.
Okay.
So these skills videos, did you guys, Jade, were you able to see that skills video when I shared my screen with you?
When?
Right now. You're just watching it.
No, it just has me on the presentation.
It has you on the PowerPoint?
Yeah.
Okay, so you guys need to get into your Davis nursing skills videos and watch the skin videos for skin integrity and wound healing. That's what we're going over right now. So I need you to do that. And then when you're doing that, you can pause them. And there are different scenarios that you have. You all got them uploaded, right? To all these scenarios, like I need a break, halitosis, got uploaded to Brightspace. So you'll need to, depending on if it's a wet to obtaining a wound culture, which is halitosis, you're going to pause that video and do some assessments and documentation and finish this and turn it in. Okay. So instead of you having patients in the lab, you'll use this and use the patients that are on the Davis skills videos. It's worth 5 points. So you'll then actually just email it to me. Cool. So really, you probably don't need to be on here anymore.
Okay.
So you can just view those videos and complete those sheets.
Okay. And so I went and got tested. I'm supposed to tell you hello from Heather.
Hello from Heather. I love Heather.
I was reading my book and then she's like, "Oh, are you a student at Briarcliff?" And then we just had a huge conversation about you. So I'm supposed to tell you hi.
Hopefully all good things, Caitlin.
It was. We were talking about your cooking, so.
Perfect. Perfect. Well, you guys can log off, watch your skills videos, complete this, and turn it in by tonight, okay?
Okay.
Midnight tonight, okay?
All right.
Let me know if you have questions.
Okay.
Okay. All right. So halitosis, we went over how. We're going to do a dry dressing change on Eileen Dover. And Eileen Dover is over here in the corner, good old Eileen. I'm gonna set the checklist for you here. Eileen had a cholecystectomy. She has a wound. She also has an abdominal binder on. You guys want to go over here so I can show you the abdominal binder? Kind of nice to get a visual. Privacy. Provide privacy. Right? Okay, so she has a binder on, which isn't unusual for a patient who's had abdominal surgery. So always when I'm doing dressing changes, you know the rules, your 12 safety checks, 2 patient identifiers, things like that. Because you could work on a surgical floor where you have, 4 different folding susceptibles that you're taking care of, and you went into the wrong patient room and do the wrong order. So if you take this off, you'd have your gloves on, of course, and it's Velcroed, okay? So I just usually take it off. This is a 3. You can get kind of a 2-panel or a 3-panel or a 4-panel abdominal binder. This is a 3-panel. So there's like 3 strips is what that means. Okay. Some people need a 4-panel. You just have a longer torso or a bigger abdominal area to cover. Okay. So this is what her wound looks like when I take the binder off. Okay. And I'm going to have to change it. And I'm going to do for this dressing change, I'm going to do a dry dressing change. So what I'll do, I'm just going to show you this. For example, we'll watch the video on how to do a dry dressing change. But I'll have gloves on, just like in the video. So I'm going to look at the wound. I'm going to do my assessment. I'm looking at the dressing too. So I want to have a garbage by me because I'm going to throw that out, change my gloves, do my piping, and get ready to do the actual dry dressing change. Okay? So I want to look at the amount, the type, the amount, the color, and the odor of drainage. How much would you say, how much drainage do I have? What are those words that we use? Scant, small, moderate, large. Okay, so I would say this is small, right? Okay, you'll also notice that I have my initials, the date, and the time. Okay, I need to have my credentials. What are my credentials? All right, what are your credentials? Yep, so you would put your initials SN ECU. So whoever says, hey, who did the dressing change last time? They can look at this and see. And plus, it kind of covers your tail that you did your dressing change. Because sometimes dressing changes are twice a day. So, and sometimes it doesn't get done twice a day, which is a problem. So make sure you're writing on your, and you write on it, not on the patient, you write on the safety before you put it on. Okay. Yeah. Just a second. Let me get that. Okay. I don't know that we've talked about military time. You know we document military time. Okay. So you know how to tell military time? Does everybody understand military time and how we get military time? Okay. So what would 1 o'clock military time be, Kayla? 1300. So you, in the afternoon, you're going to take it plus 12. Okay. So what would 4 o'clock in the afternoon be? 1600. So what would 5 o'clock be? What would 5:45 be? 17:45. What would 11 o'clock at night be? 2300. So any documentation that you do, it has to be in military time. It is never AM or PM. You never document like that. So know your military time. One recommendation I have for you is changing your cell phone to military time. Do you have a Fitbit or do you have a Garmin? I'm not sure about a Garmin. I know you can go onto your app and change it through your app, and then it changes your Garmin. Try that. So change it to military time. Another thing, when you are nursing, so if you don't know military time, change your phone. So when you look at your cell phone, you always see military time, and that'll kind of provoke you to learn how to use it. Okay. As far as your watch, it needs to have a second hand. So especially when you're doing vitals, things like that, you have to have something. Okay, so you're gonna do a dressing change on little Miss IV. So putting this back on, sometimes when we did like abdominoplasties, which is a tummy tuck, we would need 2 people. So Mackenzie, you wanna come over? So we need 2 people to get this thing tight enough. So we would actually stretch, and I would put it as tight as I could, and then make sure it's straight, and then Mackenzie would come over. Yep, because we want to get good support. All right. And sometimes this holds your dressing on. Sometimes you don't need tape then, because this will hold on to your dressing. Okay. So next, let's watch. We can go back to our your dry dressing, and this is like a 2-minute dry. These real people crack me up.
When removing and applying dry dressings, follow these steps. Cleanse or cover a work surface. Place the patient in a comfortable position that provides easy access to the wound. Perform hand hygiene and apply clean, non-sterile gloves. Gently loosen the edges of the tape of the old dressing at an angle parallel to the skin. Hold that edge with one hand and gently raise the edge until it is taut, but not pulling on the skin.
So you never
Using your
rip
other
dressings
hand,
off,
push
okay?
down on the exposed skin at the point where the tape and skin meet. Push the skin off of the tape.
I think y'all know how to take tape off, but don't rip.
Beginning at the edges of the dressing, lift the dressing toward the center of the wound.
She's wetting it because
If the
it's
dressing
sticky.
sticks, moisten it with normal saline or sterile water before removing it completely. Assess the type and amount of drainage on the soiled dressing. Dispose of the soiled dressing and gloves in a biohazard receptacle. Remove the cover of a tray of sterile 4x4 gauze. Moisten the gauze with sterile saline. Apply clean, non-sterile gloves. Gather a 4x4 pad by pulling the 4 corners up toward the middle. Use the center ball of the gauze to cleanse the wound. Gently cleanse the wound with a saline moistened gauze by lightly wiping a section of the wound. Wipe from the center toward the wound edge, or from top to bottom, or dirty to clean, depending on the wound. Repeat as needed, discarding the gauze in a biohazard receptacle, using a new piece of gauze with each wiping pass. Discard the gloves and soiled gauze into a biohazard bag. Reassess wound for size, color of tissue, amount and type of exudate, and odor. To apply a new dry dressing, wash your hands or use an antiseptic hand rub at the bedside. Open sterile gauze packages on a clean, dry surface. Apply clean, non-sterile gloves. Apply a layer of dry dressings over the wound. If drainage is expected, use an additional layer of dressings.
So that's gauze, and then we use what we call an ABT.
Place strips of tape at the ends of the dressing and evenly spaced over the remainder of the dressing. Use strips that are sufficiently long to secure the dressing in place. Tape the
Everyone
dressing
has their
around all
own
edges,
way to
window
secure the
paning if
dressings.
appropriate. Remove gloves, turning them inside out, and discard them in a biohazard receptacle. Perform hand hygiene and record the date and time on the dressing. Assist the patient to a comfortable position with the call device in easy reach.
Sometimes there are special situations that you will encounter during the procedure. What if the gauze becomes dry between dressing changes? Moisten dressings with sterile saline before removing them. Change dressing more frequently and/or consider using a semi-occlusive dressing. What if the patient has multiple wounds? The most infected wound should be treated last. Remember that you always change your gloves in between wound dressing changes.
So if you have different wounds on the leg, you'll do different glove changes and make it a whole new procedure for each one of them. Okay, so the dry is going to be, this is the dry. Anita break is the wet to damp. Ooh, we're good. Sorry, if I moved over. And then Anita break is going to be a wet to damp, and she's here. And then your transparent film is going to be here. Anita beverage. Anita has a skincare, and so she has a transparent dressing on her right elbow. Wet to damp, and then I will let you guys do your dressing changes. Please move this window from the shade.
When removing and applying wet to damp dressings using modified sterile technique, follow these steps. Cleanse or cover a work surface. To remove the wet to damp dressing, place the patient in a comfortable position that provides easy access to the wound. Perform hand hygiene and don clean gloves. Untie the Montgomery straps.
Just a different way to keep the
Beginning with the
dressing in
top
place
layers,
is a
lift the
Montgomery
dressing from
strap.
the corner toward the center of the wound. If the dressing sticks, moisten it with normal saline or tap water before completely
And that's an
removing.
ABV that
Remove
she's taking
first
out.
from one side of the wound, first toward the wound, and then from the other side. Continue to remove layers until you have removed the entire dressing. Assess the type and amount of drainage present on the soiled dressing. Dispose of the soiled dressing and gloves in a biohazard container. Perform hand hygiene. Remove the cover of a tray of sterile 4x4-inch gauze. Moisten the gauze with sterile saline or water. Don clean procedure gloves. Gather a gauze pad by pulling the four corners up toward the middle. Use the center of the gauze to cleanse the wound. Using gauze moistened with saline or filtered water, gently wipe a section of the wound from the center toward the wound edge. Discard the gauze in a biohazard receptacle and repeat in the next section using a new piece of gauze with each wiping pass. Assess the wound for location, amount of tissue present, exudate, and odor. Discard the gloves and soiled gauze into a biohazard bag. Perform hand hygiene. To apply a new wet to damp dressing, open a sterile gauze pack tray and SurgiPack. The amount of gauze you use depends on the size of the wound. Moisten sterile gauze with saline solution or filtered water for irrigation. Don clean gloves. Squeeze out excess moisture from the gauze. Apply a single layer of moist fine mesh gauze to the wound. Be sure to place gauze in all depressions or crevices of the wound.
And
You may need to use forceps or a cotton applicator to ensure that you fill deep depressions or sinus tracts with gauze. Apply a secondary moist layer over the first layer. Repeat this process until the wound is completely filled with moistened sterile gauze, but do not tightly pack the gauze into the wound. Do not extend the moist dressing onto the surrounding skin. Cover the moistened gauze with a SurgiPack. Secure the dressing with tape or Montgomery straps.
I've never ever
Remove gloves and then dispose of gloves and materials in a biohazard waste receptacle. Perform hand hygiene. Assist the patient to a comfortable position with a call device in easy reach. Gently loosen the edges of the tape of the old dressing. Hold that edge with one hand and gently raise the edge until it is taut, but not pulling on the skin. Using your other hand, push down on the exposed skin at the point where the tape and skin meet. Push the skin off of the tape.
Sometimes there are special situations that you will encounter during the procedure. What if the gauze becomes dry between dressing changes? Moisten dressings with sterile saline before removing them. Change dressing more frequently and/or consider using a semi-occlusive dressing. What if the patient has multiple wounds? The most infected wounds should be treated last. Remember that you always change your gloves in between wound dressing changes.
She's very soothing, isn't she? All right. The transparent one, I think you can kind of go through that on your own. So I want you to get into your groups. You'll each do two to a station. So the one is going to actually use the I have these, sorry, procedure steps. So one of you can kind of go through the procedure steps, and then the other one can do the change and then switch out. Okay, this is your wound part. So this is what would be outside of the patient room. Instead of, we don't really have the gauze in the containers, so I just make do. So these are already open, but you'd always check the packaging to make sure what's in. These were Curly's in here. So if you want, split up. In the room over here is Foley catheters. So two of you can go there. Two of you can do vital signs. And the rest can be switching through wounds. So we'll go through, we'll do, let's see, 10 minutes at a station. Okay? 10 minutes with these stations. Okay?
Nope.